Good morning. This is the study session for October 8th, 2022. It's 10:14 in the morning. I had logged on to see if anyone wanted to do this, and unfortunately, it looked like there's only a couple of you that logged on, including Sean, who had just had a baby, so congratulations, Sean, on that. Um, I am glad to see that mom and babies are doing well. So I decided because we only had a few people that were interested in actually being on it, I just go ahead and start the recording live and just record it for you guys and then post it for you. So this is just going to be a quick Slido quiz to go through. I will post a link to the quiz as well as the link to the video, obviously, once I get it uploaded for you. So we're going to go through a couple of questions here. So the first question here is, what following position is most effective with a patient with advanced chronic lung disease for recovery? So going through this, obviously the four choices are supine recumbent, seated forward leaning, side lying symptomatic side, and prone with pillow at waist. The idea here is what positions is best for recovery, right? So the recovery position is seated forward leaning, where you're actually leaning forward on the seat, kind of forward seated. PTA is working with a patient who has COPD, which of the following expectations would be likely found due to the patient's respiratory status. So we have chest wall decreased, decreased rib excursion with respiration, uneven rise between contralateral sides of the ribs, decreased respiratory rates. So the patient has overall COPD, right? So when we get to the answer here, right, the reason they're going to have decreased rib excursion is because the lungs themselves are no longer filling as effectively, right? Uneven rise between the contralateral sides would be there's a problem with one of the sides of the lungs, maybe pneumothorax or something like that. The chest wall itself isn't decreased, and usually they get barrel chest from COPD. And the rate itself is going to not decrease. The number of times they breathe in and out, it's just that you'll have a decreased movement of the air coming out of their lungs. Patient in phase 2 cardiac rehab used circuit training to their visit. One station is upper extremity body ergometer. What principle is correct at this given workout? So we could have higher systolic and diastolic BP. Exercise capacity will be reduced due to higher stroke volumes. Heart rate, blood pressure will be higher. Heart rate will be higher while systolic blood pressure will be lower. So the patient is inpatient or is in phase 2 cardiac rehab, right? So in phase 2, they're starting to recover. So higher systolic and diastolic blood pressure is wrong because diastolic shouldn't change that much. The exercise capacity will be reduced, but not due to higher stroke volumes. Higher stroke volumes would actually increase the exercise capacity. Heart rate and blood pressure will be higher, obviously, right? As they exercise, both of those will go up. And typically when they say blood pressure going up, they're really truly talking about systolic blood pressure going up. And then heart rate will be higher while systolic blood pressure will be lower. That just doesn't even make any sense. Which of the following would be a precaution to consider before performing first rib mobilizations, right? So precaution would be something we want to warn about. Reflexive guarding, long-term prednisone use, concurrent inhalation therapy, or functional chest wall impairments. So looking at that, the main idea here, so reflexive muscle guarding is going to happen, right, regardless. It's not necessarily a precaution. Concurrent inhalation therapy, not necessarily going to really affect that all that much, and it may actually help improve their inhalation. Functional chest wall impairments, while important, when you're mobilizing the first rib down in here, we're not worried about the chest going in and out. The main idea here is long-term prednisone use for potential osteoporosis. We don't want to fracture that first rib. PTA is gait training a patient with cardiac disease. During the activity, patient becomes hypotensive. What is the physical therapist's most appropriate response? Immediately contact the supervising PT. Stop activity, sit the patient down, elevate the lower extremity. Offer the patient a sugary drink. Decrease the speed of walking and double the distance. Well, for this one, obviously, if you have one where the patient's having problems, the first option is always to stop that activity. And then you have to determine if they are going hypotensive or hypertensive, right? So in this case, the patient's going hypotensive, right? So if pale, raise the tail. If red, raise the head. So in this case, they are going pale, which means then you want to stop the activity, sit the patient down, and elevate those lower extremities. Obviously, you may contact supervising PT, but that's not the first thing. It's not like you're going to be like, hey, well, hold on a second, just stand here in the hallway. I got to go tell my PT. You don't know that it's a blood sugar issue, so you wouldn't want to offer the sugary drink, right? And you don't want to increase the speed of walking, double the distance, because, well, that doesn't make any sense. PTA is working with a patient who has lung disease and is on a pulse oximetry. The patient's O2 levels are approximately 92 to 94%. The PTA should stop treatment and notify the PT when the pulse ox initially drops below what level, right? So here we have 78%, 82%, 88%, 90%. Give it a few more seconds just to kind of come down. And in this case, obviously the proper answer is the bottom answer, and I can't get it to show up there, just so I can go back so you can see it. Right, so dropping below 90% is the goal for anything that drops below that. We want to be careful of. Can I make it go away? Hold on here. How did I just make the controls go away? Anyway, below 90%, you definitely want to notify the PT. Now, depending upon if there's COPD, it may be lower than that, maybe 82 to 85%, or 88 to 85%. But for a normal patient, if they drop below 90, we're concerned. Which of the following methods best teach a patient segmental breathing? Place hand over the area of less ventilation and apply pressure as the patient breathes in that area. Place both hands over the lateral ribs. Apply gentle pressure during exhalation and increase the pressure at the end of exhalation, asking the patient to inhale against resistance. Place hand over the lower abdomen and apply pressure at end of exhalation. Place an incentive inspirometer in the patient's mouth and encourage the patients to breathe deeply. So we're teaching them segmental, meaning broken apart breathing, right? In this case, you're going to place the hand over the area of less ventilation and apply pressure as the patient breathes in that area. So if we're doing diaphragmatic breathing, right, we're going to put a little bit of pressure on the belly so they can feel that belly expanding. If we're doing chest wall expansion, right, we're going to put our hands at our ribs and feel those walls expand. So the goal is so that the patient can also not only feel the pressure of the actual proprioception of the pressure, but also then kind of get them a cue that it's actually working in the proper direction. The patient is status post 3 days MI, so myocardial infarction. Which of the following activities is contraindicated? Upper extremities using 5-pound weights, exercises that increase heart rate 10 to 15 beats per minute over resting, exercises in the 2 to 3 minute range, sorry I got something in my eye, and then short duration exercises. So we'll give a few minutes to think through this, right? In this case, if they are in the early phase of cardiac rehab, any form of upper extremity exercising is typically contraindicated. Now, just general against gravity or, gravity eliminated, stuff like that, not contraindicated, but adding weights to the upper extremities increases the cardiac workload and could cause them to have a relapse of the myocardial infarction. So definitely be careful with that. Which of the following contraindications to percussive therapy is common for patients with COPD, with just chronic pulmonary disease? So again, contraindications: reflexive muscle guarding, wheezing short of breath, poor chest wall excursion, or functional chest wall immobility. Give a few seconds to kind of think through that. Well, in this case, reflexive muscle guarding is not going to be a contraindication. That's going to happen. Wheezing and shortness of breath, probably going to happen as well. Poor chest wall excursion could be a precaution, but it's not going to be a contraindication. If the chest wall is completely immobile, meaning that it has gone fibrotic, or there's problems with the bones themselves in the chest wall, that would be a hard contraindication because you could damage the patient further. Patient in cardiac exercise class develops muscle weakness and fatigue. The the PT exam reveals lower extremity cramps and hyporeflexia. The patient has frequent episodes of hypotension and dizziness with changes in the ECG. What does this find? All right, so now we're looking at either hyperkalemia, hypocalcemia, hyponatremia, or hypokalemia. So kalemia, potassium, calcium, right? Natremia, sodium. So you have to know your electrolytes here. And in this case, if the patient has lower extremity cramping, hyporeflexia, meaning the reflexes aren't firing, it's typically because their blood potassium is too low. So they have hypokalemia. Now, the problem with this, unfortunately, a lot of the symptoms for hyperkalemia look a lot like that as well. So the main idea here is because they're in cardiac exercise, typically they're going to end up with low potassium. So hyperkalemia is usually your safe answer for this one. What intervention is the primary focus for a child with cystic fibrosis? We have postural drainage, pursed lip breathing, assisted coughing, or diaphragmatic breathing. So postural drainage, pursed lip breathing, assisted coughing, or diaphragmatic breathing. So in this case, we're looking at this and going, okay, what is our primary focus for the child, right? And the primary focus is to get the fluid out of the lungs because the lungs are becoming fibrotic. So the main goal is postural drainage, putting them in positions where the lungs can drain via gravity. Yes, we might teach them pursed lip breathing, assisted coughing, and diaphragmatic breathing, but the primary focus for child with cystic fibrosis is going to be postural drainage. Patient has recently and successfully completed a 2-week of phase 3 cardiac rehab will most likely demonstrate a decrease in which of the following: heart rate at submaximal work, carbon dioxide elimination at maximal work, cardiac output at maximal work, or stroke volume at submaximal work. So it's asking which of the following are they most likely to demonstrate, to show, right? So in this case, they're already at phase 3, so they're getting fairly far along in their cardiac rehab, right? And so at that point, their heart rate itself should not raise as much when they're just doing submaximal work. So they're in that low MET range or that low RPE range. If they have a decrease in carbon dioxide elimination after maximal work, we got a problem, right? That means that they're building up carbon dioxide more than that. They shouldn't have a decrease in cardiac output. Actually, the cardiac output should go up slightly if they're in phase 3 of rehab. And stroke volume should slightly increase as well, so they should be improving, right? And the main sign there of improving is that heart rate at submaximal work. Patient is prescribed digitalis, digoxin, will demonstrate the understanding of the adverse side effects of this medication by recognizing the importance of physical therapist assistance on which of the following symptoms during exercise: confusion and memory loss, slowed heart rate, involuntary movements and shaking, weakness and palpitations. So digoxin is a heart med. Give a few minutes to kind of think through this one. A few moments. And the main idea here with digoxin that we're monitoring for, well, confusion and memory loss, not typical with this medication, right? Slowed heart rate typically will happen with this, but that's not necessarily a side effect, adverse side effect, right? Involuntary movements and shaking shouldn't happen, but weakness and heart palpitations are definitely something they need to pay attention to because that means the heart's not pumping effectively, and that could happen with digitalis. Patient with a complete spinal cord lesion at C6 exhibits signs of orthostatic hypotension. What is the appropriate course of action? Reacclimate the patient to the verticals, walk the patient in the parallel bars, stop activity, change the vertical position, check the catheter, have the patient push through their dizziness. One of those you should rule out automatically, right? That being, have the patient push through their dizziness. We don't necessarily want them to fully push through their dizziness, right? Give a few more seconds. And the proper answer here is reacclimate the patient to the vertical. Right? We want the patient to be acclimated to going vertical at this point. Patients develop congestive heart failure after a myocardial infarction. What pulmonary signs and symptoms may be present? Inspiratory wheezing and shortness of breath, crackles and cough producing thick yellow mucus, crackles and barrel chest. So difficulty wheezing and shortness of breath, crackles and cough, so their lungs are cracking and popping when they cough. A cough producing a thick, goopy yellow mucus. Or crackles and barrel chest. So again, they're developing congestive heart failure after MI. So crackles and cough are the most common. And again, this would be with which side heart failure? Obviously right side, that would affect the lungs, right? Now left side can develop it a little bit as well. Or sorry, left side of heart failure is left side of lungs. I messed that up. I apologize. So left side is definitely the lung variant, right? And we typically talk about congestive heart failure. A lot of the times we're talking more left-sided heart failure than right-sided heart failure, especially if we're talking about the lungs. You should pretty much assume it's left-sided heart failure. Unless we're talking about swelling in the body, and then that's right-sided heart failure. So in this case, it's asking, they've got CHF, what likely signs are they going to have in their, with their lungs, right? And they're going to have crackles and, just odd sounds in the lungs, and they'll have this unproductive cough. That unproductive cough is a sign that their lungs are kind of backing up. A home health PTA is treating an older patient, right? On this day, the patient is confused and presents with shortness of breath, generalized weakness. What does the PTA suspect is occurring, right? So they have shortness of breath and generalized weakness. They have a mental change indicative of early Alzheimer's, unstable angina, early signs of MI, or forgetting to take the prescribed HTN meds. Hopefully one of those you can rule out. Okay, so shortness of breath, generalized weakness is an early signs of MI. What else would you want to watch for? Any type of chest pain occurring, especially pain with just mild activity or at rest, right? Unstable angina, that's definitely, that's not necessarily a condition at that point. That means they're going into possible MI. So not necessarily taking the HTN meds are going to cause that as well. A PTA is preparing to perform postural drainage on a patient. Which of the following precautions for postural drainage? Again, not a contraindication now, precaution with the patient. Humeral fractures, claustrophobia, rib fractures, congestive heart failure. So humeral fractures, claustrophobia, rib fractures, or congestive heart failure. We're looking for a precaution. Right? And so going through these choices, the main problem that is the precaution here. So humeral fractures, not really a concern for postural drainage because we're beating on the chest, not on the arm. Claustrophobia is a precaution for traction, not necessarily for a patient with postural drainage. Excuse me. Rib fractures are a contraindication, not precaution. Congestive heart failure is our main concern because we're putting them in Trendelenburg position where the head is down. And especially if they have something like right-sided heart failure, even left-sided heart failure, really, with the lungs being drained at that point, right? With the pressure increasing on the heart, you could actually overload the heart and send them into a myocardial infarction. So we definitely want to watch out for postural drainage issues if they've got congestive heart failure. We may end up having to do postural drainage in more of a supine position with less overall decline. Or we may not be able to do postural drainage at all depending upon how bad their congestive heart failure is. Patient had an MI 4 weeks ago. Which best represents the restrictions that should be followed for resistive training using weights to improve muscular strength and endurance? Intensity should be kept below 85% max voluntary contraction. Exercise tolerance greater than 5 minutes with no changes in angina or ST segments. Initiate program at 4 to 6 weeks as long as heart monitoring is used. Wait until post-acute phase 3 cardiac rehab. So what is the best option for resistive training using weights to improve muscular strength and endurance? Exercise intensity below 85% of max voluntary contractions. Exercise tolerance greater than 5 minutes with no changes in angina or ST. Initiate program at 4 to 6 weeks, or wait until post-acute cardiac rehab. The best option here is the one that specifically mentions chest pain, angina, and ST segments, so no ST elevation. All right, remember we talked about that QRST wave, so that we have no changes in that ST wave. So that ST is when we're starting to get into the repolarization of the ventricles, right? So no changes in chest pain definitely is the major one there. And honestly, looking at that one, that's the most detailed of the answers, and that's probably your best option at that one. A PTA is working in an outpatient clinic, has been assigned a group exercise program with a patient in phase 3 rehab, other cardiac rehab. For this phase of rehabilitation, which of the following interventions is most appropriate? Resistive exercise less than 15 pounds and seated. Slow performing AROM of the upper extremity, lower extremity. Walking on a treadmill at 2 miles an hour. Running on a treadmill at 5 miles an hour. So at this point in phase 3, we know that we're able to start definitely doing some resistive training. So that's a possibility, right? And we know that we can do some cardio training as well. So that's a possibility on the treadmill. But your best option at this point, because phase 3 is typically considered when we start resistive training or increasing that resistive training, right? Slowly performing AROM of the upper extremity, lower extremity is more in phase 1, phase 2, right? And then walking on a treadmill at 2 miles an hour, good lord, that's slow. And I wouldn't suggest necessarily putting a patient in cardiac rehab and a run at 5 miles an hour either at phase 3, and not maybe until they're discharged. But the main idea here is when we talk about phase 3 rehabilitation, we're talking about actual going through cardiac rehabilitation, adding resistive training. All right, last question. What is the preferred treatment position when one is providing strength exercise for a patient diagnosed with pulmonary edema? So we're doing strength training, right? Pulmonary edema. Supine with legs elevated. Seated with legs in dependent position. Side lying over a pillow. Prone with head lower than lower extremities. So pulmonary edema, not body edema, pulmonary edema. Supine with lower extremities elevated. Seated with lower extremities in dependent position. Side lying over a pillow. Or prone with head lower than lower extremities. The best option here is seated with lower extremities in dependent position. All the others could be a potential, except for side lying over a pillow, right? Side lying over a pillow is kind of the red herring there. But the other two are for swelling in the lower extremities, right? So that would be more of edema in the body, less of edema in the heart or the lungs, right? In this position, is it possible that their lower extremities could get edema? Absolutely, right? But seated is the best position to perform exercise with a patient with pulmonary edema, because in any other position, you could end up increasing the pressure on those lungs and cause bad things to happen. Yay, no one participated because no one was here, right? So just thinking through these questions, this is just a basic of some cardiac rehab questions. We're actually going to go through a cardiac rehab kind of review session as well. I just wanted to get you guys kind of thinking of some cardiac rehab questions and some ways of going through it. Short video, obviously, because I didn't have a ton of people here to review it with me. But what I'm going to do is I'm going to go ahead and post this for you guys. Again, no one showed up, so I just recorded this. And as you can see, I'm in beautiful Lake Havasu here for a funeral, so it's not like I had a great internet connection as well. But I'm going to go ahead and start recording this, and as I record it, I'll upload it to YouTube, and it should be posted within probably 45 minutes here of me dropping this. I'll also include a link to the Slido, and I'm also going to include a link to the Google Drive where I have a lot of previous study sessions as well. So I hope you guys have a great weekend, and I will catch you on the flip side hopefully next weekend.